Hello, I am Dr. Sashank Doshi, and you are watching the 577th edition of the non-stop edition of the Dr. KKs Medtalks. Let's have the headlines for the day. So we know that COVID still continues worldwide, and we have the Center for Disease Control saying that they want to add the wastewater surveillance for COVID as a part of the knowledge on the COVID community spread. Just yesterday, the DCGI has granted approval for the single-dose Sputnik Light vaccine, and we know that that is something very, very important. And they wanted, Dr. Reddy's lab wanted Sputnik Light to be a booster dose. We also know that the 8.33 lakh adolescents have received the first dose, and 0.39 lakhs have received a second dose since January 3rd in this age group. And Delhi has almost 10 to 14 lakh beneficiaries which have received the vaccination between 15 to 18. Data shows that Kerala has crossed the peak in the third wave, but it is yet to be seen if the cases will completely decline or plateau similar to the two waves. So we don't know whether there will be a thick tail. That's something which we'll ask our panelists with us, my friend Dr. Rahul Pandit. The Union Health Minister Dr. Mansukh Mandviya has launched an intensified Indradhanush 4 mission to catch up the gaps in the immunizations of the various rounds of COVID vaccination. And in the 416 districts, the Indradhanush will try to catch this. Today's topic for the day is role of mefenamic acid in COVID-19. Before I introduce the topic, let me introduce my good friend Dr. Rahul Pandit. I'm grateful to him that he's joining at midnight from Australia, and he is really one of the world's foremost leaders in critical care medicine. He has a dual attachment in India at the Fortis Hospital and in Sydney in the critical care unit there. He has been at the forefront of the COVID war, and he has been very, very actively involved in evidence-based critical care medicine. He has popularized the concept of tele-ICUs. He has been on the Supreme Court appointed state national task force and the Maharashtra government task force for COVID-19. Before we begin our shows, I would like to pay our condolences to Bharat Ratna Lata Mangeshkar ji. So we will observe a minute of silence, and then I will ask Professor Pandit to give his initial introductory remarks on inflammation and COVID, and then I will go straight to the topic of the day. So, Dr. Pandit, what is your insights on this whole topic and concept of inflammation and COVID-19? Because today we are going to discuss a very unique topic of role of mefenamic acid in COVID-19. So, before I go to the core of the topic, can you give us some insights on inflammation and COVID?
Good evening, everyone. Sir, just before I begin, I would like to say that it has been absolutely heart-wrenching to hear about the sad demise of Bharat Ratna Lata Mangeshkar ji from here in Australia. I can say that all the Indians as well as many Australians absolutely loved her, and we are going to miss the Saraswati of India. Absolutely, no doubt about that. And our condolences and heartfelt condolences to the family as well. The first and foremost, sir, in terms of your question, I think there are two or three things which happen in COVID, which we have known since almost 2 years now. And as we've got to know about it, the role of inflammation seems to be coming up. So this inflammation is essentially, in simple language, if I would say, for a layman to understand, for our people who understand more Hindi, it is Sujan. Yeah, and that Sujan, which basically happens, the inflammation which happens at the cellular level, it happens in multiple folds. It releases some amount of proteins, the bad proteins, which we call as cytokines. It sort of causes inflammation of some of the target organs, such as the vasculitis, which is seen in the vessels, as well as there is a huge amount of swelling of the other organs, the inflammation of the other organs if they get involved. For example, you may have inflammation of the heart in form of myocarditis. You may have gut inflammation. Sometimes you actually have an inflammatory reaction seen into the lungs which is the most common one, which was seen in the second phase or second wave of our Delta crisis, which we went through last year in the month of May to July, and that was essentially what we would term as cytokine storm. So all of these are set of different gradations of inflammation. But when we generally talk about inflammation, we talk about the process which releases these bad proteins and causes some amount of cellular hyperinflammability at the organ level. And we have understood that this inflammation is one of the major causes for a patient to deteriorate. And if we can deal with it in a reasonably quick fashion, we may be able to have identified those patients quickly, give them something to curb this inflammation down, and we may actually help them in not progressing from a mild or moderate disease to a severe disease. So that's our inflammation in general. Of course, there is too much to talk about it. You can actually talk on 2 or 3 webinars completely on inflammation, because the process is so wide and has an applicability right from head to toe in terms of organs which will be involved. But for the topic of the day, the mefenamic acid, I think it's a perfect topic to be discussed, and its role in playing in curbing the inflammation down. So back to you, sir, for more details on this.
So thank you, Rahulji. So we know, as you rightly said, that COVID is an acute viral disease, and it has a dysregulation of inflammation and immune response, and it in turn inhibits the development of protective immunity. And it is a symptomatic COVID which got in the forefront in the current pandemic of Omicron. We know symptoms are very heterogeneous, but the headache, the fatigue, the myalgia, the arthralgia, the fever, the sore throat, the cough, they are all manifestations of viremia and inflammation. So it's an immunoinflammatory or an inflammatory thrombotic disease. We know NSAIDs had a role. Initially, the role was a little controversial, and we know that in early management, it could lead to lymphopenia and immunosuppression. But mefenamic acid, the topic for the day, is a unique molecule. It's a unique NSAID. It's a very old time-tested NSAID from a safety standpoint. It's antipyretic, it is analgesic, and it is anti-inflammatory. So obviously, initially there was a series of 5 cases, and even I have used them in the initial parts of the COVID treatment to reduce fever, because it reduces not only fever but reduces CRP. It may prevent cytokine storm. We need to generate good science on that, but clearly there has to be an anti-inflammatory impact. And therefore, we know that in COVID myalgia and post-COVID myalgia, I have been using extensively mefenamic acid, particularly even in long COVID. And a lot of the thermoregulatory disturbances of fever and pain, which occur even post-COVID, the CRP reduces to 1. We also know that the safety and efficacy of mefenamic acid reduces PAS. What is PAS? Patients reaching an acceptable symptom state. We know that walking, talking patients, this is not for hospitalized patients, their duration of symptoms can be severely restricted. So in the Omicron wave, I have used mefenamic acid, and particularly it has been useful for people with headache, sore throat, and retroorbital pain, because there the impact is marked. In the nose and throat COVID of the Omicron, symptomatic treatment mattered, and clearly the symptom reduction was quick and fast. And the reason for that is because it not only reduces the pyrexia and analgesia, but it reduces inflammation. And we know that the COX blockade is down-regulating some of the key mediators. So what is unique about mefenamic acid is it reduces the NLRP3, which is nucleoside binding oligomerization domain receptor like containing pyrine domain 3, which is an inflammasome. And this NLRP3 inflammasome is the one which makes a lot of cytokines loco-regionally or systemically or pulmonarily. And this processing of the pro-inflammatory cascade is kind of blocked, because the mefenamic acid has been shown selectively to block the NLRP3 inflammasome and the release of IL-1 beta independent of the COX-mediated inflammatory pathway. We have also seen, in fact, I got early experience in mefenamic acid on chikungunya, and clearly it enhanced effects of antiviral drugs like ribavirin. So clearly it has a role. And does it have some adverse events? Because the challenge is adverse events. Usually the drug is well tolerated. You can get gastritis. You might sometimes need to give them with some PPIs. So the IMA and the CMAO and Dr. Agarwal, I remember very clearly, 500 milligram 3 times a day for 7 days was then advised, particularly if the HSCRP was high, including post-COVID states, with or without paracetamol. So that's something as a standard of care which was advised, particularly in the first and the second wave. So clearly that data is there. Recently, a double-blind placebo-controlled study has been published in the International Journal of Molecular Medicine, conducted by Guzman Escobar, where they looked at efficacy of mefenamic acid with standard of medical care versus standard of medical care alone, and it was impactful and effective as far as COVID was concerned. So clearly there is data. There's good data to show that anti-inflammatory agents might be a little more potent than just using a simple paracetamol. And symptomatic treatment being the key and inflammation being the key is at the epicenter of all this. So when we are actually handling many of these agents, particularly related to in the COVID space, we definitely need to understand that mefenamic acid works on two things. It modulates the immune defense, and also it has an impact on inhibiting the viral entry by inhibiting the formation of M28. So that is one mechanism of action of mefenamic acid. And because of the selective inhibition of the NLRP3 inflammasome and IL-1 beta inhibiting VIRAC, it also inhibits the synthetase enzyme, thereby neutralizing the effects of the preformed prostaglandins. And selectively, it inhibits the 2-AG and the oxygenation of COX-2. So clearly, we have data to show that whether it is IL-1 beta, IL-6, IL-18, TNF-alpha is all down-regulated. The NLP1 inflammasome is blocked, and the serine protease and the viral replication is also blocked. So these are the unique things, and because of the dual mechanism of action of mefenamic acid, it is there. Paracetamol, we know it can only trigger the release of DAMs, but so it reduces the prostaglandin synthesis, but it doesn't have any peripheral action, and it's weak on anti-inflammatory action. There are other anti-inflammatory agents which have also been tried, but they are not impactful always against the NLPR3 inflammasome. So one of the agents is indomethacone. It had conflicting results because it can cause enteropathy as well as cause pancreatitis. But it does have a prostaglandin blockade role. And the other agent is naproxen, which inhibits the NK kappa beta, but doesn't have any impact on the NLPR3 inflammasome. So these are the other agents. So therefore, when you compare all these agents, clearly mefenamic has some role beyond just antipyrexia, and it clearly has a role in myalgia and inflammation in the recovery. Because when there is people are knocked out often, I found this drug, particularly in the Omicron phase, which is predominantly symptomatic, a very, very useful substance. So it's very, very important to recognize 2-3 things which I'm teaching you today. That number one, in symptomatic disease of Omicron, clearly we need a anti-cytokine agent which will improve the inflammasome, which is NLRP3 inflammasome. And in this NLRP3 inflammasome blocking, the cascade of the SARS-CoV-2 viroporins, clearly this blockade works. And this blockade definitely is an option in the treatment paradigm of modulation. And that is something which we know that we need to do that. So we have to always balance NSAIDs in COVID. We know that NSAIDs reduce the risk of developing severe COVID. They improve the recovery and prevent the progression of severe and critical disease. They reduce the viral entry and replication. They inhibit the NF-kappa beta and NLF-RP inflammasome and inflammatory cytokines. They enhance the type 1 and type 3 interferon responses and antiviral CD8 cells and NK cell responses. They repress the formation of Th1, Th17 cells. And they inhibit the migration, activation, and function of monocytes, macrophages, and neutrophils. However, every agent which works potentially very well also needs careful pharmacovigilance for adverse events on gut, kidney, and the heart. It can exacerbate eczema and allergy, so you have to be very cautious and careful. You can sometimes get prolongation of bacterial respiratory infections. So if there's underlying bacterial infection, it needs antimicrobial treatment under appropriate guidance. It may make a little bit of hypercoagulable state. It might enhance secretion of certain inflammatory cytokines. It may reduce the host immune responses, and it might enhance the formation of NETs. So those are the cons of it. Having said that, current data with the double-blind placebo-controlled study being published is pretty compelling and unique. So when it comes to a dual blockade of anti-cytokine viral load, it's a useful tool in the current paradigm. As I said, in the current paradigm, it is the sore throat, the headache, the backache, which is the key. And reduction of inflammation is pretty critically useful. So that's why it's important to focus on this. As I said, the focus on COVID in the Omicron wave is nose COVID and throat COVID. But more importantly, we have to save every life. So we need to ensure that we focus on two things: symptom control, and after symptom control, ensure that there is no deterioration in the lungs. So Dr. Pandit, two questions. First is that in the COVID space, now Omicron is clearly on the decline. Where do we go from here? And I would like you to illustrate to our viewers from India, how is a country like Australia? So we would like to hear from you the Australian experience of COVID screening. So you could just give us your journey from India to Australia. What all did they do? Because now people want to travel out. So I am sure that the MedTalk viewers would like to know, how does one travel safely in the COVID times? How safe is it? Are you quarantined? What are the rules and regulations? What is it that Australian government expects you to do? We would love to hear all that, Dr. Pandit.
Thank you, sir. I think your short note on the mefenamic acid was fantastic. I think mefenamic acid is grossly been underutilized in the various forms of precipitation of the COVID symptoms which are seen, and the utility of mefenamic acid for that. And I really feel that there is a lot of space for mefenamic acid to be used judiciously in these patients who have these multitude of symptoms. Especially, I think it probably has got a very good role in post-COVID syndrome as well for body ache. And as you rightly said, you've been using it, I've been using it for post-COVID syndrome as well. Active COVID people who have throat pain, people who have a lot of body ache, 2 or 3 days of mefenamic acid actually just cures their whole symptoms, and they are on the path to recovery. Now, coming to my Australian experience, I think the world has matured to a point that they now understand that it is just not possible for us as human beings, as one nation, one world theory, to remain just in one corner of the world. We are all going to travel. World is a small village. It was a small village before, and now we all need to sort of get back to that concept. And obviously, that concept needs to be delivered in such a way that we don't appear to be reckless and allow the virus to grow back again. But at the same time, we allow the economy, the travel to start up. And that's exactly what the Australian government has done. Australian government essentially lets the states decide, just like India, what restrictions they need to put on their citizens and arriving passengers from international airports or from the docks. And each state has got its own set of rules, though more or less they are pretty similar, except for one state, which is Western Australia, which is still very strict and not allowing any visitors from outside. For New South Wales, which is where Sydney is, you need a RT-PCR negative report before boarding a flight, which is more of a airline requirement and the government of Australia requirement. And then when you arrive here, if you are fully vaccinated, and they recognize people who are fully vaccinated as those who have taken the WHO approved vaccine and have completed 2 doses in the last 12 months. So those are the ones who are fully vaccinated. If you've taken an additional dose, which they here call it as booster dose, in India we are very clear that we are actually using that as an additional dose, then they consider that you've been given a booster as well. After landing here, if you're fully vaccinated, you need to go straight to your accommodation, which is your home or your hotel. And once you reach there, within 24 hours, you have to take a self-administered antigen test, a rapid antigen test, a lateral flow test. And until the test result comes, you have to be isolated. So we all did that as soon as we came in. Within the first couple of hours of coming home, we did that. Once it is negative, you're allowed to step out of the house with full mask, but you're not allowed to visit high-risk areas. High-risk areas are hospitals, old age homes, correction facilities, so on and so forth, where you may have people who are residents, and if the infection does unfortunately go there, then large number of people who are actually in a confined space like a hospital might get positive. So they don't allow us to go there. On the 6th day of arrival, there is another lateral flow test which I have to take. And if that test is also negative, then there is no restriction. I can visit the hospital, I can do things. So at least for 10 days, that means you are essentially not allowed to go into high risk areas, but your day-to-day life is certainly going on. You can visit offices, you can visit grocery stores to buy things and stuff. So that's how the life is currently going on. Obviously, we have to be very honest about ourselves, and we have to do the test ourselves. They rely on people being responsible. So you do a test, you take a photograph of that, and you keep it with you. In case a custom officer or somebody from the customs calls you up, we need to show them the evidence that the test was indeed done. So I believe India will also move to the point where a day-to-day disruption of life, as you've already said this in previous shows with me many times, that by the middle of this year, hopefully, and we all only can hope because nobody can be 100% sure about COVID. But from what we have understood in the last 2 years, by middle of this year, we will come to such a situation that day-to-day disruption of our life will not happen, even if a new variant comes, even if this disease just continues to sort of simmer on to what level we are right now. And that is because we will have to learn to live with the virus. And that is what we need to do. We need to learn to live with the virus. We need to make sure that in close spaces, in people who are in proximity, you need to wear a mask. We need to be responsible citizens and complete our vaccination. So in Australia, that's another thing. Everybody is required to be vaccinated unless you are medically being excused from getting vaccinated. So if some condition is there which actually does not warrant you to have a vaccine, then they would sort of allow the relaxation in that person. So that's a very, very small population who have got allergic reactions to virus. Otherwise, all of them, in fact, many of them have vaccinated themselves. The anti-vaxxers lobby is not huge. It is small, but nevertheless, those thoughts are there in a democratic process. You will always have people who don't wish to get vaccinated, and you will have to essentially accommodate them as a population as well. And that is what probably would happen in India as well. So I think, sir, in the next 3-4 months, we should be looking at quickly ramping up our facilities to such a level of safety that we should be able to function regardless of what is happening with COVID. And that should not be, again, in a reckless way. It should be in a responsible way, that we don't allow the infection to flare up. At the same time, some level of infection will be there in the background. We will not be able to quickly stop that. Perhaps it might continue for a few more months. It might continue for another year. We don't know for sure. But it definitely looks like COVID is on a decline, and it will probably remain that way. So those are my thoughts on where we head from here on.
So that's very insightful, Dr. Pandit, and I would just echo what you said, that we have to learn to live life with COVID now. As the wave abates in India, in abroad, we have to live with COVID. So if you have to live with COVID, all the people who are above 45, 50, ensure that they get double vaccinated with a precautionary dose if it is eligible. Ensure that if you are having an underlying illness or immunocompromised state, be more cautious and careful. Wherever possible, follow strictest of COVID appropriate behavior, which include double masking when you are in close contact, in close spaces, in crowded places. That's very, very crucial. Try to maintain a distance. Try to maintain also proper hand hygiene and fundamentals of sanitation. And once we do that, it is very crucial and important to recognize that. So this is something which is very crucial to do, and that's very, very critical in the overall strength of doing the needful. What is equally important is that Omicron is still around. Symptom-based treatment is still the key. And in symptom-based treatment, it is treating fever, it is treating pain, it is treating cough, it is treating nasal block, and therefore you will have to give symptomatic treatment. For example, if there is fever, antipyretic. If there is inflammation like sore throat, etc., anti-inflammatory. We discuss mefenamic acid-like drugs. Paracetamol is always there as a backbone. If there is persistent cough, which is non-resolvable, maybe an inhaled budesonide. If things still don't look okay and you have persistent of headache or backache or any other pain or inflammation or myalgia, Probably again, mefenamic acid is not a bad option. Look at the NLPRP3 inflammasome. Beyond that, we also, if you are above 50, you have more than two comorbidities, you can still look at molnupiravir. It's not a bad option in select cases who are symptomatic and who are at high risk for deterioration. So remember, right now, what red flagging is to identify people at risk and focus on them, treat people symptomatically, and save every life. That's the current focus. Predominant strain now worldwide is Omicron, and we have to hope and pray that is a no new variant. But be sensible, be safe, be responsible, and be prudent. That's what we are there. Don't forget cardiometabolic issues. Don't forget a statin with a low dose of antiplatelets. Don't forget simple things like yoga, pranayam. Don't forget, which Professor KK Agarwal used to always say, the CRP and CBC. Don't forget post-COVID syndrome. Don't forget simple micronutrients, that's C and D. So ensure that have a very comprehensive symptom-based approach. But the most important thing is the mental health pandemic. So Dr. Pandit, my last question to you is, last week the budget for India was presented, in which two things are the key. One is digital health and second is the mental health. And the consequences of COVID have led to a boom of anxiety, to panic, to depression, to uncertainty. So a mental health pandemic also has ensued. And that is why the focus is back on mental health. And you see that more acutely when you are in the ICU setup, I'm sure. And the second is that there is a movement towards digital health. And Dr. Pandit has a vision for our country. He feels, and I have a vision for the country, that every person who needs care can be digitally connected with the doctor. In the remotest part, we are available for them digitally. And even for ICU, there is a concept called tele-ICU, which Dr. Pandit wants to promote. So first, Dr. Pandit, your thoughts on mental health pandemic, and then your thoughts on the, which is a national mission now, and then your thoughts on digital ICUs. How do you visualize it? How do you conceptualize it? And then maybe I'll just get one take-home message and we'll close our show.
Sure, sir. I completely agree with you that mental health, unfortunately, has indeed been at a pandemic proportion. It has sort of gone shoulder to shoulder with the COVID-19 pandemic. If you look at the amount of sufferings, while at one end we talk about our success story of how India has managed the pandemic quite well, there is a parallel end on the other side of the coin, which is people who have lost their near and dear ones, people who may have lost the earning member, the bread earning member of the family. People may have had family members or themselves in the hospital for a prolonged period of time, receiving various therapies like ventilators and tracheostomy tubes and BiPAP and HFNCs. Some of them unfortunately lost jobs because the economy did take a dip initially. Now it's obviously coming back up again, but initially there was a big problem. And most importantly, just by the fact of having so much of negativity around and people were sitting at home, I think a lot of people went through what we would now call it as depression, or some of them went to post-traumatic stress disorders. Some of them have gone into a panic situation of what future holds for them. And all of these things, which were not very well recognized in the Indian scenario, have now become the center stage for discussion. And I think the more we talk about it, more people should become cognizant of the fact that they need to seek help for it. And it is not a psychiatric problem. It is an issue which can be solved with just talking to somebody who is sensible. Sometimes you need drugs to calm yourself down. We see that quite often in the ICU as well. ICU, it is even more prevalent, sir, because at least in the outer world, you have people and their faces to recognize. In the ICU, the patients are only seeing us in PPE kits. They are not connected with the family. To make it worse, they are always in the tube light or the fluorescent lights, and they are never actually kept in the sunlight. So the day-night cycle or the sleep-wake cycle gets disturbed as well. And all of these things are complicating their mental issues. So I think mental health is very, very important. Coming to the second question, your telehealth, tele-ICU or EICU, what I call it. I think we as a country should unanimously stand up and say, as doctors, that not one citizen should be deprived of good medical care, even in the remotest part of the country. Now, it's a very bold statement to make, but to provide that, you would require 3 times the number of doctors which are there right now. And majority of our doctors are unfortunately centered in and around the big cities. Some of them are going to the rural areas, but not everywhere. And if you talk about specifically about ICU, intensive care is just being picked up as a specialty in the last 2 years now by common people. And if you want an intensivist in every hospital in this country which has got an ICU, whether it's a 5-bedded ICU or a 50-bedded ICU, you would probably need 4 to 5 times the number of people who are there already practicing intensive care, which is just not possible. But what is indeed possible is that a remote ICU management system, which is eICU, can connect at least 500 patients at a time with 1 or 2 doctors sitting remotely in one corner of the country. And they would be able to help the physician or the anesthetist there who is managing these patients to manage these patients more effectively so that we can save lives. And what are the things which we can do better? If I look at the intensivist profile, and this is something which I keep on saying even on national television, and when we are on a national platform right now, 80 to 90% of my job is cognitive. Is cognitive means I need to think, how am I going to make this ventilator work? The 10% of that ventilator job is actually putting the tube into the trachea and connecting the patient to a ventilator, which is a hand skill. Now, fortunately, we have a lot of anesthetists and physicians who possess those hand skills, but they have not gone beyond and took the training for actually the cognitive skills which I'm talking about. So these cognitive skills can easily be shared on a digital platform, and they can be utilized in patient care very, very effectively. And while they may appear to be subtle skills, trust me, we have spent 3 years, 4 years learning them. And even after 25 years of practice, I would say I'm still learning it, because there is so much advancement happening in the field of medicine. And there are 3 or 4 fields where I think the research has just gone on a different level. One of them is Professor Joshi, your field, endocrinology. We were talking about diabetes control. Now we talk about diabetes cure. We talk about continuous glucose monitoring. And there are so many other drugs which have now come, which are more safer and easier and don't have side effects. The second branch is oncology, where we obviously know that cancer and its different forms, we have now identified the genes and receptors which are responsible for it. And from chemotherapy, we've now moved to immunotherapy in cancer. And the third field is critical care. In critical care, even the position of the patient on which we ventilate has changed now. We are now proning patients more often than what we were doing before. I think all of these things have added on to these 3 branches proliferating to such a level that no one individual can now say that I'm a complete physician, but I practice endocrinology. Well, they would be able to practice a part of it, but it would still require endocrinologists to do the whole job. And similarly, it would require intensivists to do the whole job. And this can easily be shared. This 80 to 90% of cognitive skill can easily be shared by a doctor sitting anywhere. And we should make sure that every Indian has got access to this. No Indian in any ICU in this country should ever fall short of specialized care which needs to be delivered to him. That's the vision, sir. We both of us carry, and I'm pretty sure in the next 6 to 8 months we would strive hard to bring it under one umbrella and to try and make it more successful and more reachable for people in the rural parts of the country. So that's my take on mental health and tele-ICU. Your final comments, sir, before we stop the show.
So I echo your thoughts and sentiments that physical barrier is no more the barrier for accessing medical care. Whether it is simple office consultation, community-based consultation, home-based care to critical care. So that is what Professor Pandit was echoing. And the second thing is that the uncertainty is ending. The unknowns are getting known. We know the pattern of COVID. We know that the likelihood of another contagious and virulent strain is less likely. But we can't be complacent. We need to be cautious and careful, not reckless and stupid. And we have to walk the path. I think it's just a matter of time. We have to learn to live with COVID. COVID will become like any other disease like dengue and malaria. And we are living in pandemic times, difficult times. But we are moving slowly and slowly towards a disruption-free world with COVID that needs happiness in life, kindness in life, gratitude in life. And that is why mental health is so important. There is no scope for being negative. We always have the tunnel of hope at the end of the day. And I think that is something for which the living spirit of Dr. KK Agarwal stood for. He stood for hope, he stood for gratitude, he stood for kindness, and he stood for positivity. He always said, whatever happens, the show must go on. And COVID or no COVID, the show will go on. And we know that our common goal is only one: health of every human being with disease or without disease. And more important than just physical health, it is happiness for every human who is undergoing any chronic disease or acute disease, as well as happiness for every individual on planet Earth. So if you are healthy and happy, and we are able to find that Guru Mantra of health and happiness, that's the way to live. Thank you so much, Dr. Pandit, for joining us at past midnight from Australia in Sydney. And we are grateful once again to the entire team of Dr. KK's Medtalks for this 577th show of Dr. KK's Medtalks. You will meet once again tomorrow with one more show of Dr. KK's Medtalks. Till then, thank you so much. Before we meet on the Jopa show next week.
Thank you, sir.